question and answer, and we'll start with this one right here.
Okay. I do remember. Okay. There's a question online, and actually somebody submitted a very similar question, which is going to go to Dr. Werring. It's a quality of life issue related to depression. Depression, not just with superficial siderosis, but also the fatigue that comes with deferoprone. What is the best way to treat someone like that? And are there any medications, maybe this one's for Dr. Haddad, that might interfere with Faraprox, if that's what you're taking? Are there antidepressants that are more compatible? Maybe we'll start with you, David.
Thank you very much, Michael, for that question. So let me recap, check I've understood it correctly. It's about if there are symptoms of depression and fatigue in someone who's taking deferoprone, what are the...
And how to manage those symptoms.
How can you manage those symptoms? Well, I suppose the first thing is to make sure that the deferoprone isn't causing some kind of blood problem, so depletion of iron stores or abnormalities in the minerals that we heard about in the excellent talk earlier today. So you'd want to be excluding medical causes that could be potentially treatable by reducing the dose or discontinuation. And then you'd want to work out the relative contribution of whether it's fundamentally a sort of depression, anxiety, neuropsychological problem, or whether it is fatigue or a combination of the two. And obviously the management of anxiety and depression will be usually some combination of talking therapy with or without medication and exploring the reasons and the dynamics behind the symptoms. And that will often involve some kind of discussion about pharmacological treatments. And I hope to be educated about the best antidepressant to use with deferoprone, but typically we would use sertraline or citalopram or something like that. And fatigue, I think, is more difficult if we think it's not a depressive illness, but it's fundamentally a fatigue problem. And I don't know any easy answers to this except graded exercise, trying not to overstretch the boundaries and the limits. So doing small chunks of activity, gradually building things up. So if it's to do with working, you want to just gradually reintroduce the hours that you might be doing per week. So those would be my initial thoughts about that question. Shall I hand over to...
The question is interaction with deferoprone and antidepressants. Well, as I showed you, the pharmacokinetics of the deferoprone, it's metabolized by UGT enzyme. Most of your regular antidepressants don't go through that pathway. So, but, there's always a but. There's a lot of antidepressants. I'm not a psychiatrist. There's always antidepressants coming onto the market. Always make sure when you start deferoprone, have whoever is starting it, check with your wonderful PharmDs that are sitting there asking for you to ask for their help, and sometimes we don't use their help that much, to check for any drug-drug interactions. At least, whoever is starting that drug, just glance through the mechanism and any interaction. You have a lot of, physicians have nowadays a lot of online help that can actually check for that. But usually, no, your common antidepressants don't interact much with it.
You can hold on to that. Okay, next question is for Natallia. This is an interesting question. What does tinnitus sound like? Does it sound like hissing, humming, rumbling, something else? And does louder tinnitus, is that more concerning to you?
I think probably the best person to answer this question would be Rhys, who reported tinnitus in various forms. There are different descriptions and varieties of tinnitus. Tinnitus essentially refers to the subjective or listening or hearing subjective sounds that without the auditory stimulus. And different patients have different types of tinnitus. Usually Well, usually the louder the tinnitus is probably more related with the greater degree of hearing loss. This is a conventional understanding, but it's not for everybody that is the case. So if you're getting worried that the tinnitus is getting worse, 100% please do get it checked out with your physician or ENT doctor or audiologist. The other thing too that would be important to look into, if your tinnitus is pulsatile, so if you feel it's like a heartbeat, this is something we would really urge then for you to discuss with your ENT to have potentially a scan to rule out an underlying vascular blood vessel problem. And the other important thing with tinnitus is if tinnitus is only in one ear but not in both. The way I describe to patients the hearing system and balance system as well is like driving a car. When the tires wear out, we don't like them when they wear out on one side more than the other. So if you have asymmetry in your symptoms, unilateral tinnitus, tinnitus getting worse, or pulsating tinnitus like a heartbeat, please, 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 I urge you to discuss with your physician, most likely an ENT doctor or an audiologist. I think general practitioners may or may not always know what to do, as this is quite a specialist knowledge, I should say.
Thank you. The next question is for Rhys. Rhys, can you please share about your experience learning how to use the cochlear implant?
Yeah, it was, so sorry, just to touch on the last question, that was tinnitus related, isn't it?
Yeah.
Yeah, with the tinnitus, personally, I just wanted to comment on that because I found that there's certain triggers for it as well, like certain foods. Stress is a big trigger for tinnitus, and other things is about trying to stay calm and knowing what sets it off. And talking is one of the things that sets it off for me. So it's about trying to gauge it and manage it, I guess. But yeah, it's I get all various sorts of tones of tinnitus. I said to Natallia yesterday, I often describe it like dubstep music. I've got all sorts of sounds going on. It's like a mad rave going on in my left ear at the moment. But I think I just try and switch off from it when it's there, and I know that noise really induces it and makes it louder and louder, which is what I found difficult when I was trying to play my guitar again, because I can't hear what's going on because the tinnitus gets so loud. So it's just trying to find ways to manage it and to reduce it, which again, stress is one of the main things, and tiredness and fatigue as well. In terms of the cochlear implant, it was near enough instant for me. I can remember when I had it switched on, it was a fantastic moment. My mum and dad were in the room as well at the hospital, and yeah, they switched it on. I could add instant speech recognition. Again, it's not the same for everyone, which I was fully informed of before I had the surgery. But I do think, for me personally, it was a case of having lots of exposure to music and various sounds, and music was a big part of my life. I think that actually helped me, and the cognitive side of it as well, trying to maintain your brain function by learning and things like that, just to keep your mind active. I think that was a big part of me having an understanding and be able to recognize speech. At first, that I couldn't tell the difference between my mum or my dad or the audiologist in the room. They all sounded the same. It was quite a squeaky sound, I guess. But the way I could recognize them, I could hear accent straight away. And my mum has got quite a Welsh accent. So my dad's from Newport, which is where I was born. My mum's from the Valleys, and the audiologist was from London. And I could tell from the accents, but over a few days, it instantly kicked in, and I would say it near enough sounded like I remembered it, but I'm not sure whether that's just muscle memory. But it was quite a straightforward experience for me. But again, it's different for everyone, and I think it depends on the person, from my opinion.
Can I add something?
Yeah, sorry.
Do you remember the song you played in the car after?
Yes. So the audiologist said to me, I think it was Amy, said to me, don't listen to music just yet. But I was going home in the car, and Queen, I think it was Queen, one that come on the radio, and what song was that? I can't remember. You probably remember.
I remember you said to me it was I want to break free, and I think it was so appropriate, wasn't it?
It was an incredible experience. It actually brought tears to my eyes to be able to hear again. It was nearly 5 years of being completely deaf, and what my mum was saying in the background, I walked outside and I could hear the rain on the hood of my coat, and it was a surreal experience again. And there's the little things you miss like that, and the cats meowing and all those sort of things. So it was a really, really nice experience. Yeah.
Thank you both. Dr. Schievink, can the presence of hemosiderin in the spinal fluid change CSF dynamics, the circulation of spinal fluid? Can blood in the spinal fluid do that?
I mean, it theoretically could, but we don't have any evidence of that. It's just, it's very minute amounts of blood. And as you mentioned, right, your CSF gets replenished 3-4 times a day. So we don't think that that's the case.
Okay. I'm going to take the next question. Does the neurological damage we have from siderosis, does it make you more susceptible to other neurodegenerative diseases? And are there any supplements you can take? The answer is not really. Okay, it doesn't make you more susceptible to any other diseases. But the damage that's done does make those symptoms more likely to be noticeable when you have an infection or you're stressed out or you're really tired or as you age. So a lot of those symptoms will be more noticeable to you, but it's not because they're degenerating more, they're just more noticeable to you because you don't have the reserve that other people have as they age. So it's not that you're having more and more damage over time, it's just that you're noticing the symptoms more and more. And other supplements and lifestyle changes you can make, the best thing to do is to build up your endurance. So the more that you can handle walking or whatever your deficit is, you try to build endurance for that so that when you're set back a little bit from the infection or from whatever is causing a temporary disruption, you're still able to handle all your neurological functions. Dr. Haddad, next question is for you. Is there anything a person with SS can do to support the body's natural ability to clear iron?
Well, remember, your body is not iron overloaded. You have extra deposition in your CNS compartment. So technically speaking, you don't want to deplete your systemic iron because that causes more trouble for you. That's why deferriprone has side effects, like anemia and all of this. So technically, you don't want to clear the iron from your system. You want to clear it from a certain compartment, and that's where the trick is in treating this disease. So I hope I answered that question. So the answer is you need to keep eating regular, balanced diet and make sure that you don't lack on the essential vitamins and minerals. But are you gonna deprive your system of iron thinking that this will balance itself with the compartment, the CNS compartment? The answer is not. It's not a one-to-one relationship. You cannot plan that way.
David, the next question is for you. It's a kind of two-part question. Part one is, can superficial siderosis cause these transient functional neurological episodes? They're short-lived. They cause a lot of symptoms like headache and dizziness, and then it resolves. And the second part of the question is about acute episodes in general related to SS. Can you have a very rapid variant that progresses over the course of like a year? Have you ever heard of that with superficial siderosis?
Okay, thanks, Michael. So the first question is about transient neurological episodes, isn't it? So I suppose the first thing to say is that the cortical siderosis, so over the hemispheres, which is not the disease that we're interested in today, that is due to a leakage of a little bit of blood from usually an abnormal vessel affected by amyloid angiopathy in older people, and that does cause transient neurological episodes, usually migrating sensory changes like tingling going up one side of the body over a few minutes, stereotyped attacks. So coming back to siderosis, classical infradentorial siderosis, I would say that I've seen probably just a handful of people who've had partial seizures with siderosis, and at least one or two of them have had siderosis around the temporal lobes. So as we've heard, you get the Sylvian fissures can be involved, and the medial temporal lobes can be involved. I would say it's a rare effect of siderosis. I don't know what your experience is, the other people on the panel, but and perhaps you comment afterwards, but I think that's rare. Other transient symptoms like headaches and dizziness are extremely common, and I think we fully understand the pathophysiology of them, but it's a disease, as many of you will know, that you have good days and bad days, and even during the day it can change from 1 hour to the next for reasons I don't understand, actually. But certainly focal changes in function can occur with siderosis. And what was the second half of the question?
The rapidly progressive variant.
I have seen some people progress much more rapidly than others, and my simplistic kind of understanding of that is that maybe they've got a bigger leak than others, and they're generating more of the toxic free iron that is what causes the neurological symptoms in siderosis. I mean, this really strikes to the heart of one of the big questions about the disease is, why is the prognosis so different among different people? Because some people I've been following for years and years, and they're just completely stable, whereas others, as we've mentioned, do have more rapid progression. So I assume it might be something to do with the speed of the leak or their natural resilience. Maybe they've got other coincident neurological conditions. Maybe they've got a neurodegenerative condition that makes them less resilient to effects of siderosis. That can be a consideration. So I've had people with siderosis who've also had Parkinson's disease or Alzheimer's disease, which are both very common neurodegenerative diseases, and they seem to suffer worse with the siderosis as well. Those are my thoughts.
I might add one thing. It's not studied in siderosis yet, but it may be down the line with some neuroscientists. But the ferritin molecule has two multimers, high and light, or heavy and light multimers. And the neurologists here know more than I do. There's an entity called neuroferritinopathy, where you have an inherited problem with the light multimers that will cause this rapid degenerative, usually is a basal ganglia issue. However, I'm not saying that this is the case, but the variation is we don't know if there is a specific polymorphism in the ferritin molecule where it switches or it depletes certain multimer rather than the other. There was some studies in some rabbits that they kept inducing superficial siderosis by injecting iron in the CSF. And it flipped from, initially it was the high multimers more than the light multimers, and then later on towards the chronic, towards the end of it, it flipped to the light multimers. And each one has a different function. The heavy multimer is the one that actually creates the ferrous molecule. So if you think of it, if you have this high multimer at a high level, then you have more the toxic ion, the iron. If you have the light chain, you have more of the ferric that actually over the years leaches out slowly some of the others. So is there an interplay there? Are there patients with different genetic polymorphism or SNPs that will make them more prone one to the other, faster, slower? We don't know, but this is in the realm of science at this point in time.
Okay, back to Dr. Schievink. Intermittent leaks. Can you explain how that happens? Why is it that it'll bleed intermittently? Why doesn't it just bleed all the time?
Well, those are two different things, right? So intermittent leaks, I don't think that really exists. I think it leaks continuously. But symptoms might not correlate with, how much leaking is going on. And I do think there's probably a steady, very low amount of hemorrhage into the subarachnoid space that, for example, right, I don't know what you tell patients, but do you allow them to take aspirin?
Yeah.
Yeah.
If it's important, like for heart disease and things like that. Yeah.
Yeah, so that might, have something to do with it. But otherwise, I think it's a continuous type of process.
Okay, back to Rhys. Question in terms of pain.
Actually, sorry, Michael. Can I just ask, do you think things like physical exercise can exacerbate a leak if it's minor and?
Yeah, I think so.
Yeah.
So if it makes you feel worse, then you should, take it easy.
We're going to get to the physical therapy questions in a minute,
Yeah,
but first, for you, Rhys, pain management. How often do you get the Botox injections? How long does it last? And who does them for you?
The Botox therapy, I have at regular intervals, so every 3 months. But I can tell when it's wearing off because towards the end of the 3-month period, I start to get a bit more of a headache. And then when I get that top up then, which is great because I have it now exactly every 3 months, I can feel the improvement straight away. But when I was having the nerve blocker injections, I think it was initially because it's a steroid injection with a bit of anesthetic as well when the injection first goes in. I think the anesthetic was the bit that was doing the main, numbing of the pain. And then that's why they didn't last. But the Botox therapy, yeah, it's a good 3 months it lasts. But I do get a bit more of a headache towards the end of that 3-month period.
Okay. Natallia. We have a patient who has a very mild superficial siderosis. The dural defect has been fixed, thankfully. What do you do in those cases? How do you follow these patients, and when do you decide if the dural defect has been correctly repaired or if it needs additional treatment, and do you advise deferriprone in these cases that are mild?
All right. So there's several questions within one question, so we're going to go through all of them one by one. So the first question...
Let's start with the first question. If there's just a little bit of iron deposit, do you initiate treatment or do you just watch and see how they do? No symptoms, just the MRI finding.
I understand. Thank you, Dr. Levy. So in terms of treatment for hearing loss, if there is hearing loss, I would recommend seeing your audiologist or an ENT doctor to assess if there is hearing loss and how bad the hearing loss is, and the type of hearing loss really whether it needs to be treated or as in treated whether it's conductive, which can be treated and removed in most of the cases, or if it's sensorineural, the one that would be related to superficial siderosis. So in terms of treatment for hearing loss, I would say if the patient is asymptomatic, that is, they have no symptoms, the options are to advise them to contact the clinic to come back when they feel the hearing is getting worse. So they're clinically getting worse, or to offer a follow-up appointment at a considerable or reasonable interval, be it 6 months, 12 months. We sometimes offer patient-initiated follow-up so patients feel that they are in control of their symptoms. However, if the question refers to the treatment with deferriprone, then I would have to ask Professor David Werring on this.
Shall I just add, Michael? So this is about mild siderosis, isn't it? And whether you offer treatment, I think.
It's visible on the MRI.
Yeah.
but very, very mild.
Yeah, so this is something that I've encountered quite frequently. So people may have a scan for some other reason, and they've got siderosis affecting the cerebellum. They may have had a scan for a migraine or something. And so I've seen a few people like that, and a few who've got very minimal balance problems and hearing problems. So maybe they have difficulty hearing voices when there's a big crowd, or maybe their balance is problematic in the dark. But otherwise, they're high functioning, doing very well. I find this quite difficult. The policy that we have is we would try and find out if there is active bleeding. So we do a CSF to look for ferritin red cells and xanthochromia. If the CSF looks pretty active, then we'll have a frank discussion. And if they've got a dural defect that can be repaired, so there's a ventral collection that looks accessible and the surgeon is happy that it's reparable, then we would have a frank discussion about whether the risks of the surgery could be justified, given that they have few symptoms, but they're very likely to progress over the next years. So if they're very young, they've got decades ahead of them. We have repaired people, we have repaired dural defects in people with minimal symptoms. And I think we'd always try and do that before we think about deferoprome. But if we don't find anything that's surgically fixable, then we'd have a similar discussion about deferoprome, but perhaps with less confidence that it's going to be helpful. I'd be interested in other people's views, actually, including yours, Michael, actually.
Yeah, I've had these cases once in a while with really, really mild symptoms and just a little bit of iron deposits. And it's usually a conversation with the patient if they want to make the effort and do all the blood tests necessary to try to clear out that last bit of iron. I'm not opposed to it. I don't think it's necessary in every case. In many cases, people have these findings on MRI and never have any symptoms. So it really does vary. I think mild cases are not always treated. I'll take the next question too. It's about buying deferoprone outside of the USA. For those of you from the US, the drug is very expensive here. It costs about $80 to $90 per pill, and you might need 4 pills a day. So the drug is available. It's a generic. It is available outside of the US. You just go online. You could type deferoprone, Faraprox, Kelfer is how it's sold in India, and just type like online pharmacy or something like that. And you'll find that it is available online at much, much, much reduced rates, 90 to 95% cheaper. Makes you wonder why you're paying so much in the US. I don't know why. It's just very expensive here. But around the world, it's much less expensive. I was told in the UK, for example, David, you might want to comment, it's just a few bucks, a few pounds.
Yes, a few £100 a year, I think.
A few £100 a year. Okay, that's equivalent to half a week's supply in the US. And it can all be done online. There are rules, there are laws. You go on the Department of Justice website, you could read what the laws are. You're not supposed to import more than 3 months at a time, for example, or else they can seize it. But most of my patients who do this, or they travel abroad and bring the medication back, they stuff it in their suitcase and nobody seems to ask any questions. I wouldn't take advantage of this, but that just seems to be the experience.
Make sure you have a prescription with you when you travel.
Dr. Haddad is emphasizing bring the prescription with you when you travel.
Just in case they stop you at the
So when they stop you at the airport, you can say this is for me.
Can I just add something? The big cost, of course, is the monitoring. That is really essential, the monitoring. And obviously, we wouldn't be encouraging people to take the drug without a hematologist closely involved. Just worth adding that, I thought.
Just let me add one more thing. Make sure you get, if you want to do this route, go this route, get it from a country that is well respected, like in the EU zone, where they have regulatory that's very, very strict. I deal with my dad in Lebanon on a different disease. Pills, we pay a lot of money. Some pills, we get them from Turkey and Egypt and whatever that country allows import of. You need to be careful. There's a lot of counterfeit. And the regulation of that disease goes up and down. We go to normal levels and we go to bottom-out platelets because there's something wrong with the ingredients that are active in the pills. So if you want to go that route, make sure that you get it from a well-reputable country with good regulatory.
This question is about Tarlov cysts, so probably Dr. Schievink. Tarlov cysts and nerve sheath diverticula. Have you seen bleeds from those problems?
Yeah, that's a good question. So if somebody has a superficial siderosis and a big Tarlov cyst, then that would be where most people would direct their attention to. Surgical treatment of Tarlov cyst is, like I showed this morning, it's not always without risk. So what's important to do is to do some of these sophisticated scans to make sure that there's not a more easily treatable cause of superficial siderosis, such as a CSF venous fistula. And that fistula can be from the Tarlov cyst itself, or it could be from, a tiny cyst much higher up in the spine.
Okay. Rhys, physical therapy. Do you do it on a regular basis, a structured physical therapy program? Or do you do it intermittently to learn new things?
Yeah, it's a constant upkeep. I go to physical therapy, or physical therapy as we call it in the UK. I go every week, once a week, to help maintain what I've regained through doing it and to try and push that extra bit further. But I can't stress enough how important it is to do the exercises at home as well, just to keep pushing yourself. It's not, you don't go there and they just flick a switch and you're doing it again. It's a lot of pushing and pushing yourself as far as you can go. But you still need to know your limits and when to rest as well. It's important, but it's constant maintenance, and it's something I'm continuing to do to try and push to that extra bit further. But once you get to a point like I am now, it's kind of slower progress than it was at first. I noticed the big improvements from when I couldn't walk at all to when I got back on my feet again and started walking. But it's a life-changing thing. It's just beneficial for getting around in general and around the house. But I know I still need to take my stick with me at times. And if we go distances, I have used the wheelchair, like when we were in the airport, because it was quite a distance to go. It was nice as well because got to jump the queue and things. But yeah, it's a must just to keep pushing yourself as much as you can.
Dr. Haddad, question for you about the timing of taking deferriprone relative to certain meals, because the label says you have to wait 2 hours before and after taking deferriprone with orange juice, tomato juice, and other things that have high vitamin C content. Is this something that is very strict, or is this something that patients can just try?
Okay. The reason for that is technically what they're trying to do is make you less chelate what is going in to your system rather than chelate what is deposited in your system, which means you still have to absorb the iron. You need it. We'll go back to the same concept of that's why they tell you stay away for 2 hours away from, when you take it, don't eat anything for 2 hours or so. It's just for the fact that in order for you not to interfere with the actual absorption from the gut, the iron from the gut. However, also, as I mentioned, somebody asked me, it's the same principle when somebody asked me, somebody was concerned about he's taking some zinc for his as a preventative measure for macular degeneration. And he shouldn't be taking it with it. The answer is no, you keep taking it because, in fact, deferriprone causes zinc depletion or chelation and removal. So we eventually, if we find that you have zinc deficiency, we're going to give you zinc. So it is not a contraindication as much as keep them apart so that, you will not render it ineffective. You're just taking the pill and taking the deferriprone at the same time. It peaks within 1 to 2 hours. You chelate whatever it takes, so you're not absorbing much. So it's more of that mentality rather than if something bad is going to happen to you. Do you need to take it as the gospel truth? Not necessarily. You know, be mindful of it, but, you know, if, for heaven's sake, you want to grab something to eat, 1 hour and 35 minutes, you go ahead and eat. It's not a big deal.
Dr. Werring, question for you. This comes from the online group. This person with SS has no sensation and no motor function in the legs. Is this due to SS? And if so, does it steer your attention to a certain part of the spinal cord that's involved?
Complete loss of sensation and motor function in the legs. I mean, that would be unusual for siderosis. Siderosis can certainly cause myelopathic symptoms, which often can mean some degree of weakness and stiffness.
We lost the mic.
Degree of weakness and stiffness of the arms or the legs, depending on where in the spine the symptoms are coming from. And that can involve sensory loss, it can involve pain, it can involve the bibrachial atrophy that we heard about earlier this morning. With regard to just the legs involved, obviously that localizes to the lower part of the spinal cord, to the thoracic or lumbar regions. Siderosis down low in the spinal cord is often, or can be associated with arachnoiditis, which is kind of pooling of the blood and the blood products and irritation of the nerve roots, which in my experience is often very painful rather than just giving pure sensory loss and paralysis of the legs. It would be quite a painful phenomenon, arachnoiditis. So I would be very reluctant to attribute complete loss of feeling and motor function in the legs to siderosis. I'd be wanting to scan the spine again. I'd be wanting to even look for maybe neuropathic causes. I'd examine the patient and think very carefully.
I agree. I've seen a lot of patients who are confined to a wheelchair because of balance problems, but not so much loss of strength and sensation. Agreed. But hold on to the mic. This next question is for you online as well. You mentioned that you don't usually offer deferiprone to patients who don't have an active bleed. This person wants to know why that would be if the drug could potentially chelate the old iron, why you have to have new bleeding in your clinic.
Yeah, so this is a great question, and I think we don't honestly know the correct approach to this. My understanding is that the deferiprone, its main mode of action is to chelate the free toxic iron. And I'm uncertain as to whether it can actually get at the hemosiderin, which is, as I understand it, is trapped within cells called macrophages sitting under the surface of the nervous tissues. So I would be less certain that you're going to derive benefit from deferiprone if you haven't got any free iron and any active bleeding. But I can understand this might be a controversial viewpoint, and I'm very happy to hear other people's views on it. Maybe Dr. Haddad.
No, actually, he's spot on. If you remember, I don't expect you to remember, but the slide on the mechanism of the drugs, if you looked at deferiprone, is actually more effective against the F2 free iron radicals that are coming out of the disintegration of the heme. Not as much as those that are combined with ferritin. That one is more deferoxamine, which actually doesn't cross the blood-brain barrier. So he's absolutely spot on that point.
And that relates to a question regarding someone who has an inoperable bleed, and can they just take deferiprone for the rest of their lives to avoid getting worsening superficial siderosis instead of fixing the leak if they can't? Apparently their surgeon says it's not amenable to surgery.
Well, at this point in time, you deal with the hand that is dealt to you, and if you're tolerating it, and if it is that efficient in removing, because you can also overwhelm the amount of dose that is going through the CNS. So it is not a full proof that you're taking it, you're you're free and your life is going to be great and you're going to dodge that bullet if you don't fix that thing. So you don't know, and we have no curve that says if the bleeding is at this rate, then the dose that's going through the CNS, because each one is different also in how things transfer back and forth. So you can overwhelm the capacity of the chelating effect of the drug, and you still can have progressive siderosis. So the best thing is your surgeon, your gifted surgeon here.
Inoperable, is that such a thing?
Well, I mean, there's nothing that's really inoperable, but it might not be the best thing to do, of course. And and some patients don't ever want to have surgery. They'd rather take 4 pills a day for $1,000 a day.
Okay.
I was going to add, Michael, it's actually not that uncommon situation where you have something that isn't surgically fixable, and in our experience, the dural ectasia can be very multifocal and very difficult to deal with. And we certainly do have people who are on deferoprone just because it's we desperately want to offer something that could help. So it's not that uncommon, I don't think.
I'll add that deferoprone does seem to definitely prevent any worsening. Like once a patient starts on deferoprone, it's really rare that I'll ever see more deposits. It really is effective at binding free blood. The problem is how slow it chelates all of that other hemosiderin. It could take 5-10 years to even make progress on that. So that is a problem with the drug. But one of the questions for Dr. Haddad is about the new drugs, such as the one that binds the ferric iron. What are the alternatives that you see coming down the line?
Well, these are the list that I put there these are drugs in various stages of development. Remember, for every single, as they say, for every 1,000 drug that goes in preclinical studies, only probably one can manage to get through to the clinical arena. So we need to see exactly where they go, how the development is, get to know more their side effect profile, and whether it is suitable for siderosis or not. The mechanisms of actions sound great and wonderful early on, but again, everything that is early on doesn't mean it's going to actually live up to its hype. You know how many clinical trials we do, I'll go to my area, which is hematology and oncology. We do so many clinical trials, and the drugs are so wonderful, and CNN is raving about them, and it goes to a phase 3 trial, and we find out that they're not better, and sometimes they're worse and have worse side effects. So until then, it's a good thing, it's a good step, it gives us hope that more drugs are being developed in that field that we can pick from, and some of them cross the blood-brain barrier, but it remains questionable about what the outcome is and the quality of life of the patient, whether they're going to make a dent in that area.
Natallia, for you, about MRI technique. If you're having an MRI for one of these transient functional neurological episodes that we see with cerebral amyloid angiopathy, how can you tell on the MRI if it is amyloid disease or if it's TIA or if it's something else? If it's all about blood products, are there patterns that distinguish these different conditions?
I'm looking at Professor Werring. I think I shall pass again.
Happy to help, Natallia. So cerebral amyloid angiopathy is a disease of older people that some of you may know about, but it typically does affect people who are a bit older than those who get siderosis. So usually beyond 60, 70, that kind of age range and older. It's a common cause of brain hemorrhage and dementia, and we can recognize it pretty well by the imaging findings. So we're looking for bleeding near the brain surface, and that could be what microbleeds, or it could be the cortical siderosis. The cortical siderosis in CAA is different to the supratentorial involvement of classical siderosis that I mentioned earlier, because it tends to be very sort of focal and patchy in individual sulci, whereas in siderosis, in classical siderosis, because it's to do with the bleed in the CSF that circulates all over the brain, it tends to be rather symmetrical, doesn't it? So I would say it's relatively straightforward to disentangle those diagnostic possibilities. There's a few other biomarkers of CAA that perhaps I won't go into the detail of.
Good. Okay, Rhys, you talked about the change in your diet. Are there positive effects that you've seen of certain diets? Have you only tried one, or have you tried other diets?
Yeah, I'm constantly amending my diet, and it's sort of live and learn. I think with superficial siderosis, one of the things I was really suffering and still am is the problem with the bowels in the morning, and I find that eating like foods like porridge and things that are easily digested is really helpful first thing. And the other thing then, at the other end of the day, is not eating too late. And I think the biggest thing is having sort of periods where you don't eat, because it takes longer for me to digest food. And I know that if I've got a full stomach and I haven't digested it properly, it can be a trigger for all my other symptoms, including the overactive sweating, the hyperhidrosis, the headaches, the fatigue, and if I've go to bed on a full stomach, it almost wake up in the morning then feeling like I haven't slept at all, and I just don't feel rested. So I know that limiting the window that I'm eating food is a big factor in my symptoms and managing them.
Okay, thank you. This is for the whole panel. I'm not sure who to ask this one of. It's about taste. So I personally have a lot of patients who lose their sense of smell related to siderosis, but I've never had someone who lost or had a distorted sense of taste, like specifically bitter, salty, things like that. Is anyone here?
I'll start
please.
on that one because I can talk from personal experience. Yeah, my taste is definitely impaired. The things I really notice that I can still taste are spicy and sweet foods. Other things that might be subtle, I can barely taste at all. And the game with the smell as well, and obviously your sense of smell and taste are linked. Certain things I can't smell at all, like gas on the oven, for example, on the hobs. I struggle with that, and that's why I wouldn't know if I'd left the gas on or the gas was left on. And other smells I do sometimes have phantom burning smells as well, which I notice that I know aren't there, but I do get that. But yeah, the taste is definitely an issue, and I think since starting the deferriprone, I do believe that my taste and smell have come back to an extent, but I still say they're very impaired to what I could taste and smell before.
Okay. Dr. Haddad.
Yes, sir.
Deferriprone, put straight into the spinal fluid. Mm-hmm. Rapid effect, would that be better than taking it by mouth? Like an injection straight into the spinal fluid?
Well, that's a good idea, but I don't want to answer. That's a good theoretical question, but deferriprone has not been tried in that way in any disease that I know of. Now, there might be some animal models and preclinical models, but I'm not aware that they inject it directly into the CSF. Plus, in order to do that, they have to have special formulation to go into the CNS, the CSF fluid, and it has to be a certain grade. The deferriprone, as far as I know, has the formulation is only tablets, oral, not injectable. Does anyone know of anything?
No, but that's how I initially got in contact with David. I remember back in 2019. That's good.
The only formulation that I know of, at least in the US, deferriprone is only tablets, not injectables.
I also get questions, maybe Dr. Schievink can comment on this. Can you just scrape it off the brain? I mean, if it's there and it's causing damage to the tissue underneath, can't you just pull it off?
No. I mean, you can, you can resect it. But yeah, maybe you can make some, but you don't need a chelating agent then that crosses the blood-brain barrier if you do it intrathecally. You can use one of the other ones.
Correct. But again, you know, it has to be, first of all, we don't want to cause inflammation of that space and kill the patient, because some drugs are terrible when you put it in the CSF. So the companies, the only one that's injectable is the first one which we use as continuous infusion or sub-Q injections, deferoxamine, and that bypasses, correct, that bypasses the blood-brain barrier, but I've never heard that it is compatible or can be injected into the CSF.
And it would have to be multiple times. Who's willing to get multiple injections?
We can put
into
an
the spinal
Omaya
fluid?
reservoir there.
That's fair.
You can just use it like a morphine pump and just have it under your skin.
Do we have any
Continuous,
volunteers? No. But maybe someday.
Chemical meningitis at this point.
Someone kindly asked me if, since Harvard's been in the crosshairs in the news, what effects it's had on our research and recruitment of foreign students. So far, our research funding is intact. Thank you for asking. It's locked up in the court system. But our foreign students are worried. Traveling to programs outside of the US, for example, they're advised not to do since they're on a visa. So there has been an impact. But keeping our heads down, and hopefully it'll all blow over in a couple of years. I also got a question here for the whole panel about AI assist. Superficial siderosis is a rare disease. Most doctors have not heard of it. Can AI assist doctors in the community for making this diagnosis if they put in the right constellation of symptoms? Do you guys see that in the future?
I think AI is really good for the radiologist, so they don't miss it. There are a lot of scans that are misread. They said they're normal, but they're not normal at all. And I'm not talking about subtle findings.
And I forgot which, I think it was you, wasn't it you that showed the quantitation?
Mm-hmm.
I happen to have a certification in AI in medicine. It's very, very exactly what he said. It's very, very good and actually sometimes surpasses the radiologist. By using texture and borders, definition of borders, and the gradient of what the normal eye cannot see the gradient. For example, what he showed you, that a subtle change, that might be a drastic change in the amount of iron, that the radiologist said, well, you know, it's plus or minus. It's within the definition of minimally changed or unchanged. While if you get the quantitation at the pixel level, then you might say that there's a significant change in the amount of iron that is in that radiographic picture. So AI is a major force to be reckoned with when it comes to radiology, among other stuff. And they can read patterns better than human beings. They can read signals better than human beings. But to make a diagnosis up front from symptoms, they're not there yet. Then you have to train it on every disease, and every disease within a certain contextual setting and certain population to be able to give you a good sensitivity and specificity for the test. But as far as radiology, they're fantastic. They are actually FDA approved to read diabetic retinopathy without the help of any human being.
Personally, I also use it to establish travel agendas. Say you're going to Eastern Canada, it'll come up with an 8-day plan for you. That's really cool. That's AI for me there. Natallia, trigeminal neuralgia. Have you seen that caused by superficial siderosis? You maybe want to tell everybody.
Thanks, Dr. Levy. No, I haven't seen trigeminal neuralgia in superficial siderosis, but I would love to hear your opinions, yours and Professor Werring's. I have seen trigeminal neuralgia in the ENT clinics, but not with the setting of superficial siderosis.
I've seen it, but I've not been convinced it's due to the siderosis.
Trigeminal neuralgia is like a pain in usually half of your face.
Because I think the trigeminal nerve doesn't really have a sort of glial segment that's exposed to CSF.
Yeah.
So I don't think so. What do you think?
Yeah, I haven't seen any of those cases either, but trigeminal neuralgia is common. So it's one of those common things that happens to coincide with an uncommon superficial siderosis, probably. Tick bites as a cause of superficial siderosis. We had someone who wrote in and said that that's been the explanation for their superficial siderosis caused by a tick bite.
You go to Martha's Vineyard.
Ticks are common in Martha's Vineyard, and I haven't really known any cases of how a tick bite could eventually lead to some sort of bleed in the spinal fluid.
I've had 3 patients who had a spider bite, a brown recluse spider, in Texas and somewhere else. And that happened like within days of the onset of their CSF leak headache. And one of those went on to develop superficial siderosis. It's probably just a coincidence. Well, the theory behind it is that there's so much inflammation and proteolytic enzymes that get released in the body that it also can break down the dura.
Okay, there you go. All right, I think we have time for one more question, then we'll take a break. This is a question about healthcare access, maybe for both countries, US and UK. How do people who are not near these centers have access to resources like experts and deferoprone and things like that? Do you guys have any suggestions for people who do not live near academic medical centers?
Well, I wish you could travel between states on Medicaid. That would really help.
That would be a start. So what he's saying is if you have Medicaid in Texas, you can't use that Medicaid coverage in another state.
And if you would pay cash, you would lose your Medicaid.
Oh, I didn't know that. Did you guys hear that? If you use cash while you're on Medicaid, they'll take away your Medicaid. Okay. Any other suggestions?
Yeah, just say occasionally we get referrals from people who are either too immobile or they live too far away to come to the clinic. So we have a virtual MDT where we can discuss cases, we can review the imaging, we can look at the results, and we can come up with some kind of action plan. But it all has to be then delivered by a local neurology team. So you still need a local neurologist to coordinate the care, but you can get some advice from a specialist service. So I think virtual clinics might be one way of increasing equity of access. But
Virtual clinics.
Sometimes what we tell patients is just to go to Disneyland, and on their way to Disneyland, they get really bad, and they have to check in through the ER.
Oh. There you go. Dr. Schievink is inviting you to Disneyland and Cedars-Sinai while you're there. Okay, we're going to take a short break. I believe, Kyle, you said a 10-minute break, bathroom break, whatever you need, and we'll reconvene for the final half hour. Thank you so much.